All right, everyone. Good afternoon. My name is Zhao Chen. I'm a professor and associate dean for research. Welcome you all to MassConf Research Roundtable presentation seminar today. It's such a pleasure. We're going to hear three speakers from our School of Health Professions, and they will introduce their research. I think for people, students who are not quite familiar with the new school in the college yet, there's a great opportunity to make the connections. So the three presenters, uh, Valeria and Enric, Dr. Valeria Enric, Assistant Professor, Doctor of Physical Therapy Program. And we're also, second speaker is Valerie Schaibley. And Dr. Valerie Schaibley is Associate Director and Research Director in Genetic Counseling. And the last but not least, James Tracy. Dr. James Tracy, Assistant Professor in the Doctorate Degree of Physical Therapy Program in the school. So as you all have heard about this seminar is set up to help researchers and students in our college to know each other's work, to make connections, and to develop collaborations. So without further delay, and we'll welcome Dr. Enrique.
So I'm a physical therapist. I've been a physical therapist for a number of years, and I've sort of the professorship and research has sort of been like my second career, and it's been very driven by sort of the needs that I have seen from the lacks that I've seen in the clinical sphere. And so particularly with chronic pain, right? So I just wanted to give you a sort of the very broad perspective that I'm coming from. Usually people go to therapy, to PT for chronic pain, and usually we assume that it's something that has to do with like muscles or musculoskeletal system or something that is biomechanical. And that is true in a lot of cases, but there's definitely a subgroup of patients for which that is not true. And so over the years, I've sort of became really interested in understanding what are some of these systemic contributors to the chronic pain. And so hence I've got more and more involved with trying to understand different biomarkers. And I focus particularly on inflammation, neuroimmune dysregulation, and how they impact the chronic pain. So I'm going to go through the slides a little bit more quickly than I had previously thought, because I thought I had more time. So if you have any questions, I'm going to go a little quicker over the methodology, of which I'm very happy to talk to you about. If you have questions in the end, I can talk about it for hours. So yeah, careful what you wish for. So, okay, so as I was mentioning before, there's a lot of different causes to chronic pain. So biomechanical is obviously something that we all think about as therapists, but then there's inflammation, psychological, social factors, just to give you a broad sort of understanding. But the idea is that there's a lot of heterogeneity between different patients. So each one can have a slightly different variation of like how much each of these categories is contributing to. So I was really interested in trying to understand among all of these factors, how much of each is contributing and how much, and can we have a better understanding? Can we have a different sort of line of treatment depending on what these causes are? So I'm going to talk briefly about 4 projects that I've worked at, or I'm working at. One is diet-related inflammation, which was my master's project, and then gut microbiome and plasma cytokines were from my dissertation for my PhD. And then I'll just mention a little bit about the current funding that I have. Okay, so the dietary inflammatory index is what I use to assess the diet contribution and musculoskeletal pain in the adult population of the US. I used the NHANES dataset, which is really very useful because it's publicly available and it's really well done. It has number of cycles. So the basic idea here was that diet contributes to inflammation, and then inflammation we know that has contribution to pain. So what I did was I used this dietary inflammatory index, which had been already very well established in research, and I used it against certain variables that describe pain, such as, for example, joint pain, aching, and stiffness, often associated with osteoarthritis, pain in the spine, pain duration. So I'm not going to go through all the methodology of the DII, but just so you know, it is based on very robust evidence that is based on circulatory biomarkers. And so you get this DII value that is like continuous variables from negative value to positive value, depending on if the diet is overall more anti-inflammatory or more pro-inflammatory. And so you can see here in the here are some of the results that are showing both unadjusted and adjusted results. And without going too much into the details of each one of them, I just want to point out that there are a lot of like significant categories here. Particularly, you see the OA symptoms are significantly associated with more pro-inflammatory diet. Presence of symptoms for most days in the past months is associated with pro-inflammatory diet, low back pain, pain that lasts longer than 24-hour, pain duration. So these are all very clinically relevant sort of aspects of pain, and they've all been associated in the research in this analysis. And just to put it in a little bit more sort of understandable perspective, these are quintiles, so of DII. So so divided the whole range into 5 buckets, and the bucket number 1 is the bucket with the least amount of inflammation, and bucket number 5 is the bucket with the most amount of pro-inflammation from the diet. And you can see that the odds ratio of the people with the most inflammatory diet, you can see 1.4 to 4. So that means that people in bucket number 5 with the pro-inflammatory diet had 42% higher chances of having low back pain and chronic low back pain than people with a more anti-inflammatory diet. So I think it's pretty significant. It's a pretty significant result, obviously, not just statistically significant, but I think it opens up to a lot of potential intervention. I don't know if you know, PTs recently, according to the APTA, the American Physical Therapy Association, they have this sort of ability of also including some discourse around diet, and so obviously this was done with that in mind, and I think that there's definitely some potential for including this intervention with with the inflammatory contribution from the diet in mind. Okay, I'm going to go through now the other 2 projects. One was on the gut microbiome, the other one was on plasma cytokine. This was from my dissertation work. So I had actually used data from this very large data set that has been collected at the University of Pittsburgh. This was 1,000 patients with chronic low back pain. And we collected blood, we collected stool samples, and we sort of hypothesized that people with more pro-inflammatory cytokines or higher inflammatory cytokines or higher presence of pro-inflammatory bacteria in their guts would have an increased pain and disability. So I mentioned a little bit of this population. This was 1,007 adults with chronic low back pain. We collected a lot of variables. This is a very highly dimensional data set that was collected here. So for the microbiome, I mean, after we collected the stool, we sequenced, we analyzed it. There's different methodology today to you. I'm going to spare you from this. A lot of methodology into this. I'm only going to talk about the abundance-based method. So it's just the individual taxa and some of the results, which I think is the most intuitive one, given the timeline. So it's basically saying who's there in terms of certain taxa or bacteria, and in what proportion with the other ones. So with the methodology we use, we then have absolute abundances, this with relative abundances to each other, but it still tells a lot of interesting information. And so we selected 35 taxa that represented most of the relative abundance that we found. So these are some of the results. And again, I don't necessarily want to go through all of these, but I do want to point out, so there is green arrows. So these are the results for the association with the taxa with ODI. So this is the Oswestry Disability Index, which is widely used in research on low back pain, chronic low back pain. Very robust outcome measure. And so on the green arrows are the species that are shared between the ODI and the pain. So the next slide is going to be the similar thing, but with pain. So all of those are associated in both ODI and pain, which obviously gives more potential target for intervention and understanding mechanisms. The ones that are highlighted with the orange, those were significant across all models, so both individual, multiple linear regression. But the bottom line, I think, with this one is just to try to understand that. So the top three are pro-inflammatory taxa based on literature. The central one are anti-inflammatory taxa. The last one are both, meaning that depending on what the condition was, they have been found to be either pro or anti-inflammatory. But I think you see that there are a lot of association across all the spectrum, which I think really points to the complexity of all the interactions that are happening inside the gut, and potentially this complexity, probably how it translates to modulation of the immune system, which we know happens in the gut in a very robust fashion. So this is the same organization of the table as the prior ones, and again, without going into too much into detail, you can see that there is a lot of significance there. These are, this is like from this one here, this is like half of all the taxa that we had identified had significant association with ODI, and this is like a third of all the taxa that we'd identified had some association with pain. So I think it's pretty robust sort of results, and it definitely warrants more research going forward. This is a portion on the plasma cytokines. So again, this was done on the same population. We collected the plasma. We did ELISA or ELA. So these are quantitative measurements for analytes in plasma. And then we looked at both some pro-inflammatory markers and some anti-inflammatory markers, with the idea that more pro-inflammatory markers obviously would be associated with more disability, and more anti-inflammatory markers would be associated with less pain and disability. Okay. And again, without going too much into the details of each one of these, but I just want to point out that again, there's pretty significant, pretty robust associations here across different models. This is again the ODI, so this is the disability portion, and you can see that there's significance in both pro-inflammatory and anti-inflammatory cytokines. So again, pointing at a really like a systemic involvement that is more than just like one single biomarker that I think a lot of research was trying to identify early on, and then we found that unfortunately that doesn't really work very well. And then this is the association with some of these inflammatory markers, pro or anti-inflammatory, and pain, and you see that there's also some pretty robust associations there. Interesting in this case is you can see that there's some interesting differences between the individual linear model and the multiple linear regression. So when you account for multiple, so for all of the cytokines in the model, their significance actually changes quite a bit. So some that were not significant at all become significant. So I think again it tells a story of the complexity of this response and that is going on, and really the low understanding we have of it at this point. Okay, and then just real quick, this is going to be the last bit I talk about. This is I started working here in June last year, and this was sort of like a Hail Mary sort of application for a grant that happened in 10 days, and I got it. So this is great. I'm now officially a K-12 scholar in CAPTI, which is a really amazing inter institution opportunity, because it's happening here at the University of Arizona and some of the University of New Mexico. We have regular meeting, a lot of mentoring. This has been really an amazing learning experience. So I'm going to talk real quick about, I don't have data on this, but I'll just tell you kind of like what the project is like. So what I proposed was to use NAC, which is I think it's here. Okay, the NAC or N-acetylcysteine is a compound that was originally used. So it has like it was a drug that was developed for certain things in the past, and then it's mostly not used for that anymore. Now it's mostly used because it has a support on the redox process, so it helps with both inflammation and reuptake of the reactive oxidative species in like all over the body. So I propose to do basically a mouse model and then a post-surgical model for using NAC as a post-surgical analgesia adjuvant to see if it helps decrease pain and reduce the amount of opioids that have been used. And so obviously, this is, a very big problem. There's, I think about 8 to 15% of people that undergo surgery, they become long-term users of opioids. So obviously it's a huge problem. And so yeah, that's kind of where I was going with this. So the aim one is the preclinical portion. So we're going to look at the gives you a better visual. There's like a preclinical model where we're going to use NAC and vehicle, or kind of placebo kind of thing, for a paw incision model, and then we're going to look at the differences between the different mice for Bonfrey, which is the sensitization, the local sensitization to pain, grimacing, and we're also going to look at certain cytokines. And then basically we're going to kind of repeat the same thing for people that undergo elective surgery of the lower extremity. So we're also going to give NAC or placebo. We're also going to look at pain. We're not going to poke their paw with the filament, the Bonfrey filament, but that's kind of the idea, to look at the pain and the physical function, the cytokines as well. And then the aim 3 really looks at kind of what's conserved of these inflammatory types, phenotypes across the different models, and see if that can help sort of inform future research and future grants in this area. And I think, obviously this also has more opportunities to be developed as a like also in other population, and not just acute pain, but also obviously chronic pain as well. These are the details of the specific game too, but I want to be aware of the time, and I know that they are. There's another 2 speakers, so I'm going to leave it like this, and I know we're going to have questions in the end, so I'm just going to call it for now. Thank you all for listening. Sorry that I got you.
Hello, everybody. Hello, everyone on Zoom. My name is Valerie Schaibley. I am the Associate Director and the Research Director for the Genetic Counseling Graduate Program. And I'm excited to talk with everyone today about some work that I've been doing for a few years, trying to help expand access to clinical genetic services for patients in Arizona. So when I talk about clinical genetic services, I'm predominantly talking about 2 different types of healthcare providers. So just to orient everyone, clinical geneticists are physicians that have specialized training in clinical genetics and genetic testing. And genetic counselors are master's degree trained specialists with training in clinical genetics, genetic testing, and counseling. And they have very similar but somewhat distinct scopes of practice within genetics. But when I'm talking about access to genetics healthcare providers, these are the predominant ones that I'm going to be talking about here today. So when we're thinking about how patients can access clinical genetic services, they experience multiple different barriers. And I'm going to talk about the first three today and focus first on these initial two barriers. So looking at the genetics workforce that we have, as well as distance to care, because these are two pretty interrelated issues. So the genetics workforce across the country is not where it needs to be, and it is particularly not where it needs to be here in Arizona. So this graph that I'm showing you is some data that I put together a couple of years ago, looking at two different metrics that we have for the genetic counseling workforce. There is no one standard way to assess how many people are currently working in genetics across the country. So this is our best approximation, with those little dots showing the average between these two different ways of measuring the workforce. And what we see is that compared to the projected need for clinical genetic counselors, which is one for every 100,000 people in the population. Most of the states here, if you look at where that number one is, are not reaching where they need to be in terms of the clinical genetics workforce for the size of the population that they have. And when you look at Arizona in particular, we're way, way, way down there. So we rank 40th out of all 50 states for the number of genetic counselors that we have practicing in the state for the size of our population. So not great for a population size of 7 million people here in Arizona. We only have about 0.61 genetic counselor for every 100,000 people. And this is probably an overestimate, as it is with most of these states, because that's not necessarily genetic counselors who are working in direct clinical practice. Lots of genetic counselors work in industry, education, other fields. And so all of these are probably more than what we actually have in direct patient-facing areas. The other point is that here in Arizona and across the country, most genetic counselors and clinical geneticists are located in major metropolitan areas. And that's the same here in Arizona, where most of them are in Phoenix and in Tucson. And so this really limits access to the rural parts of our state where they have to drive a very long way to see these specialists. Okay, so one of the biggest ways that we see this reflected in patient access to care is in wait times. And we see longer wait times for patients in Arizona than we do nationwide to access genetic counselors. This is data that we did with a student several years ago who did a genetic counseling workforce assessment of Arizona. And when we stratified our wait times by clinical specialty, that's what we're showing in the different colors there, we saw that pediatrics, 100% of prenatal or pediatric genetic counselors reported wait times of over 6 months, but I noted anecdotally, this is more like 18 months for a new patient appointment. So patients are waiting a very, very, very long time. We saw something interesting in this data where the two prenatal genetic counselors that we have in Arizona at the time were both reporting very low wait times. So they're the ones in red up there on the plot. They were both reporting really low wait times. And when we looked at how they're getting referrals, so their perception of how many referrals that they're getting, we saw 100% of 2 out of the 2 prenatal GCs who responded reported fewer than an appropriate number of referrals. And that wasn't just limited to prenatal genetic counseling. We saw that across different specialties. But we think this is one of the reasons why we're seeing not very many patients being referred to prenatal genetic counseling, leading to low wait times. This data was from 2022. We still have a very low workforce in prenatal genetics. We have 3 in the whole state, 1 in Phoenix. Okay, and so this tees me up kind of to talk about the next barrier that we've really studied in my research program, which is looking at provider recognition for when it's appropriate to refer patients to genetics. And we've seen consistently across different types of providers, different types of genetic testing, that there is a big barrier related to physician knowledge of when we should refer to genetics, when to order testing, and overall training in genetics. And this correlates really well with how often they do things like order genetic testing. And so this is data from another student who surveyed cardiologists across the country and looked at their use of pharmacogenomic testing in clinical practice. Most 48% of our respondents said that they were only somewhat knowledgeable about pharmacogenomic testing, and over 50% of them had never ordered a pharmacogenomic test. And this is for a type of testing in cardiology that is very, very impactful compared to other clinical practices. And when we asked respondents in that survey what the biggest barrier for them was to incorporating pharmacogenomics into practice, it was a lack of training, their own personal training in this area in order to increase what they were doing. We've seen this among other specialists. So this is another survey that one of my other students did, looking at neurologists here in Arizona and how they were incorporating clinical genetics into their practice. And so what I'm showing on the top box plot up there is the level of training in genetics among our respondents, and then their comfort overall with performing some of these integration approaches for genetics. So interpreting test results, communicating those results back to patients. What we found was a really strong correlation between their own perceived level of training in genetics and how comfortable they were with actually using this data or these types of approaches in a clinical setting. And we also saw the same correlation with how often they ordered genetic testing as well. And so this, together with a lot of other research we've done, is suggesting that expanding training for clinicians in cross specialties may help provide some more access to patients in terms of their providers being able to order that testing on their own, being more comfortable interpreting it. But the other thing that we saw in the same set of data is when we asked neurologists their level of agreement with 3 separate statements about how having a genetic counselor in their clinic would impact their patient care and their overall practice, we saw the majority of them agreed with things like having a genetic counselor would improve care for their patients. Having a genetic counselor in their clinic would save them time and would also allow them to see more patients. And so the other approach that we're trying to do is try to integrate genetic counselors across a variety of practice areas, especially here in Arizona. And why is this important? This is from a Washington Post story that was published years ago. But this is just an anecdotal story about this woman who had genetic testing because she had a family history of cancer. Her test came back negative, but it was misinterpreted by many different specialists and providers in her care team. She never saw genetics, but she saw many other providers, and they all consistently misinterpreted her results. And she ended up having a prophylactic hysterectomy and double mastectomy based on negative testing results. So some of the things that can happen when these issues are exacerbated. Okay, so what are we trying to do about it here? In Arizona, I'm really proud to say that the genetic counseling program here has really helped to expand the genetic counseling workforce. We're still very low, but we're growing. So our program opened in 2019 and graduated our first class in 2021. And this plot is showing the number of genetic counselors in Arizona over time. And the red bar at the bottom is showing the proportion of the Arizona workforce made up of our program's alumni. And I'm really, really excited that 30% of all of the ones that are working in clinic are actual graduates of our program. So we're doing a lot of work to just expand the workforce, tiny but mighty. And the other thing that I'm working on currently with one of our students who's actually defending on Monday, we're looking at some of the barriers to increased workforce expansion. And so we've done a national workforce assessment study where we're asking genetic counselors to tell us things like billing practices and their licensure status to try and get at some of the systemic barriers that may be blocking future growth of the profession. And it may be no surprise that a lot of some of the barriers we're seeing come back to billing and money and the way that our healthcare system functions. So what this is showing up here is when we split our respondents into those that are working in high genetic counseling workforce states, which is the pie chart on the left, compared to low genetic counseling workforce states, we see a big difference in just how many people bill insurance for their services. About 80% of the genetic counselors in high workforce states bill for services compared to only about 55% in low workforce states. So suggesting that there's some differences in billing patterns that may be contributing to the workforce. And then when we look at licensure status between high workforce states, which are shown down here in blue, and low workforce states, which are shown here in green, we see a pretty big difference in the licensure status of genetic counselors. So there's 15 states in the country that do not license genetic counselors. Arizona is still currently one of them, although we're very, very close. And what we see is that the majority of genetic counselors in high workforce states have licensure either in their own state or in multiple states, whereas the majority of genetic counselors in low workforce states do not have licensure at all. And so this suggests that licensure, in addition to billing and all of these factors, may all be contributing to these differences in workforce that we see across the country. And so this is just a summary, which I'll hop over in the interest of time. And then just a quick thanks to my collaborators. And then, as I said, this work has been done majority by multiple years of genetic counseling graduate students. So kudos to all of them. And if anyone wants to hear more about some of this, Melanie is defending on Monday. You can come and look at her thesis. That's all. Thank you.
All right. So thank you for this time. So rather than getting into like a single research study and all the details, I'm going to kind of cover a broad overview of my research path. So for the faculty and students here today, I hope this shows where our interests might intersect. And then also additionally for the students, I hope this also shows that your path doesn't have to be linear. They should always pay attention to opportunities that pop up and be prepared to learn new skills. So first, door number one opened for me to join a biomechanics lab at BYU as an undergraduate research assistant. So we were bringing in really high-performing distance runners and looking at how they moved. So I was running track and cross country at the time, which made this a really easy topic for me to spend extra time thinking about. And so we would bring them to the lab and put a bunch of sensors on them to capture three-dimensional motion capture, and then evaluate all sorts of running mechanics while they ran really fast on our treadmills. So then in parallel with this, another door opened for me to work with USA Track and Field sports science team, primarily doing women's and men's steeplechase analysis. So steeplechase was my track event. So again, this was a pretty easy thing to get into because I had direct experience with what I was researching. So we would film at a few meets during the season, and then including the US championships and the Olympic trials. And we provide a performance analysis report for the athletes in preparation for the World Championships and Olympics. And we also added some of our own side projects with these athletes, looking at running mechanics and other track distance events and the marathon. So through this, I saw how much less information we were able to capture during live racing compared to when we brought athletes into our lab. So we could answer a bunch of questions in the controlled lab space, but we couldn't say if those same answers would hold up in live competition. And as a master's student, I heard about an interdisciplinary research team of mechanical and electrical engineers, exercise scientists, and statisticians who were developing a smart shoe. So it included instruments embedded within the shoe itself to collect data outside of the lab. So this was a really cool thing that I wanted to use. Unfortunately, they were still early in the product development, so I couldn't use it yet for the project that I wanted to. But I was offered a position with the team to help with product development because I knew how to run the equipment and the software in the biomechanics lab that they wanted to use. So this was a really valuable experience to move into a new research space and taught me directly how powerful interdisciplinary research can be. So I got to bring the experience and skills that I already had to help the team and gain new skills and perspective through different applications of those skills. So after my master's program, another door opened that led to my PhD program. And so given my background experience now, I think the next step should be pretty obvious: to move across the country to the University of Delaware and investigate how cerebral palsy increased fall risk in young children. So this was not kind of the obvious next step and surprised me, but there were opportunities here that were unique and gave me another opportunity to expand my range of experiences. So this project produced the results that shaped my dissertation. First, we found that kids with cerebral palsy did not walk in a manner that was protective against a forward loss of balance, despite showing an impaired response to forward perturbations compared to children with typical development. So this led us to question if walking stability is something that we can proactively control. So if walking stability is something that we can modify, then we can design interventions aimed at proactively improving walking stability to reduce fall risk. To do this, I had participants walk on a treadmill with occasional really big perturbations to create a significant threat of falling, and to try to encourage participants to proactively change their walking stability if possible. So kind of the short answer is participants were able to modify how they walked that protected against a backward loss of balance. I also started exploring how balance and movement were expressed across these 4 postural control domains. So these 4 domains are previously established and describe different types of balance. So standing is its own type of balance, which is different than walking, and anticipatory or pre-planned self-initiated movements are different from reactive movements. So our lab's previous studies were supporting the independence of these domains, meaning that performance in one type of postural control domain didn't really predict performance in another. So if truly different, then clinically assessing balance in each of these domains would be really important for actually determining someone's fall risk. The short version, again, is the more we compare across postural control domains, the more support the results give to domain independence and the need for proper clinical context when evaluating fall risk. We've also kind of stumbled into something kind of odd with these data. So this is the crowd participation time. So I'm actually going to ask everyone to stand up real briefly. And what I want you to do is to stand on one leg and really focus on being stable. Okay, so stand on one leg, just focus on being as stable as you can. Okay, that's it. That's all I need to know. So now I'm going to ask a follow-up question. You can go ahead and you can sit down now. Relax now that you've moved. By raise of hands, how many of you stood on your dominant leg? Like the leg you would use to kick a ball? Okay. And how many of you stood on your non-dominant leg? So for those on Zoom, we're split 50-50-ish. So I've done this a bunch of times in groups like this, and it's always like this. There's this unpredictable split in choice between dominant and non-dominant choice. So this is an example of limb dominance not relating to limb preference, which is kind of weird. So as we balance and move, both legs are involved and are controlled both independently and in coordination with each other. So in the upper extremities is a pretty established concept of laterality, where there's a dominant limb. So laterality is beneficial because it expands the range of competent movements that we're able to perform. So it makes sense for this construct to exist in the lower extremities as well. So what we've done here is we've had people perform a whole bunch of movement tasks across these postural control domains to assess laterality. And we're also looking at limb preferences like we just did, as well as the leg chosen to perform different tasks, and incorporating traditional limb dominance and a measure of footedness, or like a degree of limb dominance. And we found essentially no relationships between these different limb characterizations. So limb dominance didn't align with footedness or with limb preference for performing tasks. Footedness didn't relate to limb preference or laterality. We even looked at limb preferences across tasks, and the limb preferred for one task didn't relate to the limb preferred for a different task, even if it was a similar movement. So people have a really strong preference for doing tasks because they choose the same limb over and over again. We do multiple trials, but none of these limb characteristics have seemed to relate to why that preference there. So it's kind of a weird thing we're still working on. So after Delaware found another door that didn't specifically have the experience to walk through, but I took another chance to learn new things. So at the University of Colorado Anschutz Medical Campus, I continued to do balance and posture control research as a postdoctoral fellow. But I applied these questions to a new clinical population of people with lower limb amputation. We also were fortunate to collaborate with an orthopedic surgeon who was one of the world's leading experts on osseointegration. So osseointegration is a fairly new procedure for limb prosthetics, at least, where rather than using an external socket to attach a prosthetic, a rod is implanted within the bone itself, and then the prosthetic components attached to that rod that protrudes from the residual limb. So I designed a new project and was awarded an NIH F32 fellowship to explore how osseointegration could potentially improve postural control across these domains. I also began exploring the effects of osseointegration on proprioception, or knowing where your body is in space, as well as this concept of osseoperception, which is like the unique capacity of an osseointegrated implant to provide sensory information to the brain from the bone. So all these areas would have significant implications for fall risk if improved with bone anchored limb use. And we found many notable improvements in postural control and a wildly increased sensory capacity through the osseointegrated prosthetic limb, such that many of these participants were also reporting the ability to detect different types of walking surfaces that they were on with their prosthetic limb. And then last year, I accepted a position here with the physical therapy program. It's kind of another surprising opportunity because I'm not a physical therapist. But here I am. So I'm taking these various experiences I've been able to grab along the way to help shape a research agenda around postural control and functional performance across the lifespan. So in particular, I'm focusing on how pregnancy and postpartum recovery affect postural control and participation in physical activity. I'm also implementing or developing simple, accessible interventions to try and improve postural control through interventions that are clinically, community, and rurally feasible. So for any faculty or students that are interested in this, I just got IRB approval for a new study looking at postural control in women who are and are not pregnant, and I'm kicking that off really soon. And I still love running and have started a side collaboration with UA's triathlon team, looking at some running mechanics and performance outcomes to improve individual level performance. So we're finalizing a simple assessment of racing shoe selection right now and are expanding this over time as we find new areas of interest. And the last thing, like I'm not alone in the program. We've heard some great things already. So I'm fortunate to partner with an incredible group of people with various background experience and research interests. So we would love to connect with more people. Thank you.
Thank you so much for the presentation. Do please to come to the stage and we'll start the panel discussion. I know today we really started late, so if you need to go to class, feel free to leave. We have this room until 1:30 for people who can stay and then carry the conversation. I'm going to pass the microphone to you. Anybody have a question, please raise your
Related to the genetic counseling, what services do you guys provide that actually require you to be in clinic as opposed to doing these over through telemedicine?
Yeah, that's a great question. And for those on Zoom, the question is about what services for genetic counseling require genetic counselors to be in clinic versus being able to do this via telehealth. Very few, to be perfectly honest. The majority of genetic counseling can be done over telehealth. The biggest barrier we have found to expanding telehealth is billing. A lot of genetic counselors bill with a facility fee, which requires them to be in the facility that they're in with the patient in order to do the billing. And so we've heard of some major clinics around Arizona who've actually limited telehealth opportunities for their genetic counseling staff because they can no longer bill for that. So it all goes back to the money. Right.
Surprise, surprise.
Yeah.
I also had a question on the
Okay.
So you mentioned part of the issue is that there's simply a lack of genetic counselors, but then another part was that primary care physicians are not trained sufficiently. I was just curious about is that they're sort of unaware of needing to make referrals, or is it more about being verification of results, and kind of what would the training or improved training look like?
Yeah, that's another great question. Sorry, for those on Zoom, I think the question was about for providers, what kind of if it's a lack of specific training or a lack of training in how to do the results, and if those are kind of the big barriers for that access to care. Is that a good summary of your question? Great. So I think it's all of the above, and I don't mean to call out primary care providers. As I said, we've seen this across specialties, with just lower levels of training leading to lower levels of confidence, and communication of these results. And so my usual perspective on that is that, the genetic counselors, clinical geneticists, they're the specialist providers, and we should be using them to do what they are specifically trained to do. I mean, PCPs have an enormous amount on their plate, and it's a lot to ask them to integrate this into an already very brief appointment. And so one of the ways we're actually starting a project with doing some education on referral indications for cancer predisposition testing with primary care clinicians. And part of what we're trying to do is to increase referrals to genetic counselors here at the Cancer Center, again, to take that off of their plate, but still provide the patients with the access to care, since PCPs often end up being kind of the gatekeepers to a lot of the other specialty care.
Maybe a follow-up to that, though, maybe the insurance. How does that?
The gatekeeping of insurance companies? Oh gosh, that's a really hard question. But no, I mean, aren't they always the gatekeepers for everything? Yeah, I mean, we were just discussing this in one of my classes earlier today about cancer genetic testing, and it was like, okay, in an ideal world where we didn't have to deal with insurance, we might consider this testing. However, that's never going to happen, and so we're probably going to do this type of testing instead. So it's always there in the background, right?
So I have a question actually for we're working with the physical therapists, so we're talking about across the board. There are a lot of interest for pain and for fall prevention. For pain, very fascinating results with the inflammation and the diet connections. And with that, for the pain and then for the diet connection, cross all the pain or joints, or is it specific for certain type of pains or regions? If you study low back pain.
Yes. So the question was if the inflammation is specific. So it seems to be specific from the results, right? Because we looked, for example, neck pain was not significant and low back pain was. I have a sense that the data that we had didn't really have all the joints, so I couldn't really do like, based on like my clinical experience, I would definitely say that that there are certain patterns, though I don't think that for much like many other topics related to pain and clinical work, I think it depends. I think there's probably different subgroups of people that have that are more prone to have inflammation hit certain joints versus others, right? And I think that could be partly like their background, partly the way that they've used their body. So like they have prior injuries or other mechanistic factor. And I think altogether, but yeah, I would say that it's probably, I mean, low back pain is more common than other conditions, right? Yeah. If I had to guess, like, I mean, I thought about it a lot actually. I think that potentially one way that I thought about it was that probably larger joints, if they have more blood flow, they may be impacted more by inflammation, like systemic inflammation, right? Because if the inflammation is coming from the blood, then the target in the specific joint may be more affected. But that's like a working theory. That's just not. That's not.
But the hypothesis to be tested.
Yes. Yes.
Wonderful. So for the pass rate control, and we, very fascinating area for research. Do you know if there any research that has demonstrated if you identify pass rate, also abnormal pass rates and correct that can prevent fall or other kind of injury?
So the question being, can we target specific postures to reduce fall risk?
Yeah.
So yes, one thing in particular I kind of think is really important, kind of the specificity of the intervention. So falling happens typically in a dynamic reactive state, and so by incorporating dynamic like training into fall prevention, I think is really important to actually be specific to when falls are occurring. So in research that's been looking at essentially practicing tripping and slipping and recovering, one thing that seems to be popping up is trunk control, in particular low back and your extensors. So by like those who have better control of their trunk and are like, for like a forward trip, who are able to slow the forward kind of angular rotation of their body, those who have better control of that have better outcomes in being able to prevent falls. So yes, we can start identifying specific postural interventions that could help reduce fall risk.
Love to talk about that. Wonderful. So I heard that the genetic area is really an exciting and new area, and students probably want to get into that. Is there any limited factors to say the number of students is small?
Yes.
Back up.
Yeah, thanks. Our class size is currently 5 students every year. And that's because there are like 35 practicing clinicians that they can train with in the state. And so that's currently limiting to our class. But if anyone is interested in genetic counseling, I'm here. Our program director, Chris, is here as well. We'd be happy to talk with anyone who's interested.
Wonderful. Well, let's put our hands together and, there's a question.
Sorry, one last question about genetic counseling, and all of these talks were so interesting. I was curious if any of your work had looked into the role of patients actually, sort of patient demand for genetic counseling, because I know when I've had genetic counseling, for instance, I brought it up to the provider, and I see in some small groups like the Ehlers-Danlos community, there's a lot of demand. But how much of an impact does that have on, providers sort of trying to learn about genetic counseling?
I think it's changing. Oh, I'm sorry. The question for Zoom was about how patient demand for genetic counseling is impacting kind of referral practices. I think it's been changing a lot since the use of genetic testing in clinic has expanded. Now that there's more testing options for a broader array of conditions, I think there's a little bit more patient demand for it, especially in specific groups like the Ehlers-Danlos community is very kind of tapped into that area. But I think a lot of people, and this was one of the barriers that I didn't talk about because I haven't really studied it extensively, is patient misconceptions about what genetics is and what it can do. And there's a whole body of research on that. It's just not my area of focus. So I don't want to mischaracterize that research, but it is a little complicated. Yeah. Mm-hmm.
Yeah, this is for the chronic pain. For those like cytokines, probably antibodies, were there any interest or like potential to stratify across like the demographics? I look for maybe some like targeted intervention areas there across like gender, race, and ethnicity.
Yes, so that was not part of my project, but the main study is like, obviously they enrolled 1,000 patients, so they, it's a very large study. There's a lot of people involved. The main goal of the main study, like the main aim, is to phenotype patients, right? And not only using the biologics, the biological part is one, and then there's biomechanical and behavioral. And so they're trying to combine actually all the three, not just
specifically those. But I did a little bit of there were some interesting differences across. Mostly I looked across age and sex, because those are really huge for inflammation. Like, we know that inflammation tends to change across, like, as we age. We know that the immune system in women is different than in men. So there were significant differences across those already that I could see. So there's definitely there's a lot of that. Yes, the lab that I'm currently doing, the project that I'm the research that I was mentioning last. There was a professor there who's doing a lot of work on the difference between sex and, like, sex hormones and the way that they impact pain experience across, female and male mice, and then with the translation in mind. So yeah, it's a huge area. Yeah. But does this answer your question? Okay. Thank you.
Line that sounds similar, but as Dr. Enrico applied to the geriatric fall prevention, and in your study has sex of the first model been considered, I have experienced that male mice were more reactive to the trauma.
Yes. So the aim one with the mouse model, it's going to be done both in there's going to be an equal number of male and female mice to control for that. Yes. Thank you. Are you gonna?
I had a question for James, actually, and you could talk a little bit more about your new study regarding postpartum women, and just sort of the hypothesis and the aim for that study. I just think it's very interesting and maybe related to what you were talking about before, the core and posture, but just curious what that happened.
Yeah, so unsurprising, there's a fairly limited amount of existing data looking at pregnancy and postpartum, just in all sorts of fields. So this is kind of our working with a colleague at another university at BYU, and we're working on a couple of projects together, and this is one of them where we're really trying to get some, like, foundational data, like what does it look like, just normative data. And so we're, for this specific one that I'm doing here, looking at some standing balance measures. And so we're looking at how individuals control their center of pressure and their body control while standing, as well as in anticipated movements, so kind of like leaning to the side, tracking, and trying to understand the limits of their stability, as well as some more dynamic movements such as like single leg stance and reaching, and looking at walking, and some changes in walking. The idea is that during pregnancy, there's significant changes in body mass and mass distribution. And so our brain has a pretty good control over our, like, whole body center of mass, our kind of center balance point. But with pregnancy, that location changes. And so there could be some changes on like potentially increasing fall risk in this population, which have serious consequences for falls. I would like to look at some more dynamic, like, perturbation responses as well. We just don't have the equipment to do it yet. And so when that's kind of next on our horizon, and so we're really just starting to see, like, what kind of things could we and should we be looking at, and being a little bit broad.
So much. Well, thank you again for our